some good upheaval in the world of borderline personality disorder. Many things we thought we knew were disproven lately, and others have emerged. All in all, more optimistic news. If I had to choose between borderline personality disorder and narcissistic personality disorder as a diagnosis, I would choose borderline. There's spontaneous remission after age 40 or 45. There is DBT, which is a very effective treatment strategy. And there is growing hope day in and day out. The more we believe, or the more we convince ourselves that borderline personality disorder is actually a form of hereditary brain abnormality, the more treatment horizons and medical interventions open. But even in the classical field of psychotherapy, there are mega developments. Stay with me for this ride, a literature review of the most recent studies in the world of borderline personality disorder. My name is Сэм Вакнин. I'm the author of Malignant Self-Love, Narcissism Revisited, and a professor of psychology. And let's delve right in and review a new study. This study upends our perception of borderline personality disorder. Before I go there, there is enormous ignorance, even among people who are supposed to know better. I just returned from a trip in July to Vienna, where I've met 13 psychologists and psychiatrists, 12 of whom had insisted that borderline personality disorder is actually bipolar disorder, not borderline personality disorder, as the name implies, is a personality disorder. And bipolar disorder has absolutely nothing to do with it. It's a mood disorder. And yet, these top-notch professionals didn't know the difference. In another country, Hungary, I've heard of the most credentialed, prestigious diagnostician there misdiagnosing borderline personality disorder, or actually the absence or lack thereof, egregiously. He hands down diagnosis to people, telling them they do not have borderline personality disorders because they don't self-mutilate or self-harm. This is a level of profound ignorance. In every civilized country, this man would have lost his license. Let me elucidate a bit. The absence of self-harm does not preclude a diagnosis of borderline personality disorder. There are new findings, and they have enormous implications when it comes to the diagnostic criteria for this disorder. And so there's a study, a recently published study, and it's titled The Hidden Borderline Patient, Patients with Borderline Personality Disorder Who Do Not Engage in Recurrent Suicidal or Self-Injurious Behavior. It was published by Cambridge University Press in July 2022, and the authors are Mark Zimmerman and Lena Becker. I will summarize the study for you, and then, as is my habit, I will read to you the abstract. And so what these people are saying, what these investigators or scholars are saying, is that you don't need to self-harm or self-mutilate or cut in order to gain the diagnosis of borderline, or qualify for the diagnosis of borderline personality disorder. They selected 400 psychiatric outpatients diagnosed with borderline personality disorder. About half the participants were suicidal, and they engaged in recurrent self-injury, self-mutilation, and self-harm. The other half didn't. Then they studied these two populations, and the results showed no difference between the two groups in the degree of impairment in occupational functioning, social functioning, comorbidity of psychiatric disorders, history of childhood trauma, severity of depression, presence of anxiety, anger, emptiness, etc., etc. In other words, these two populations were identical diagnostically and psychodynamically. The only single difference between them is that the people in the first group self-injured, self-harmed, and self-mutilated and tended to have suicidal ideation, and people in the second group didn't. And yet clearly, members of both groups qualified abundantly for a diagnosis of borderline personality disorder. Mark Zimmerman, who is an MD and a professor of psychiatry and human behavior in Brown University, Providence, Rhode Island, said, just because a person doesn't engage in self-harm or suicidal behavior doesn't mean that the person is free of borderline personality disorder. Clinicians need to screen for borderline personality disorder in patients with other suggestive symptoms, even if these patients do not self-harm, just as they would for similar patients who do self-harm. Zimmerman is also the director of the outpatient division at the Partial Hospital Program in Rhode Island Hospital. Anyhow, he published his findings in the journal Psychological Medicine. The problem with borderline personality disorder and with all other personality disorders is that they are polythetic, at least in the Diagnostic and Statistical Manual 4, 3, and 2. This approach of making a list of diagnostic criteria prevailed over the alternative approach, which is descriptive and dimensional. So we ended up having lists. Each diagnosis had its own list of criteria. And in the case of borderline personality disorder and narcissistic personality disorder, it was sufficient to meet 5 of the 9 criteria in order to be diagnosed with the disorder. But this created a major problem. Because, for example, you could be diagnosed with criteria 1, 2, 3, 4, and 5. And then I could be diagnosed with criteria 5, 6, 7, 8, and 9. And both of us would qualify to receive the diagnosis of borderline personality disorder. Yet we have almost nothing in common. Your borderline personality disorder relies on diagnostic criteria 1 to 5. My borderline personality disorder relies on diagnostic criteria 5 to 9. We have extremely little in common. And this is called the polythetic problem. So there were scholars and researchers and experimenters and psychologists all over the world who have spent the past 2 decades trying to find the single criterion which would apply to all patients with borderline personality disorder, regardless of which other criteria they had met. And they found that the only criterion which applies to 90%, that's 90%, of all patients with borderline personality disorder is affective instability, also known as emotional dysregulation. Zimmerman says that affective instability had a very high negative predictive value, meaning that if you didn't have affective instability, you didn't have the disorder. Given the clinical and public health significance of suicidal and self-harm behavior in patients with BPD, an important question is whether the absence of these criteria, which might attenuate the likelihood of recognizing and diagnosing this disorder, and they identifies a subgroup of patients with borderline personality disorder who are less borderline than patients with BPD who do not manifest this criteria. In short, the issue is this. We know that 90% of patients with borderline personality disorder have emotional dysregulation, aka affective instability. These scholars wanted to find out whether self-harm, self-injury, self-mutilation occupies the same hallowed space. In other words, whether it was also present in the vast majority of borderline cases. And what they found is no. The answer is no. You could definitely be borderline without any hint or trace of suicidal ideation, self-harm, self-injurious behavior, or self-mutilation. Similarly, there was no difference between any specific Axis 1 or personality disorder and borderline personality disorder. In other words, the comorbidity of borderline personality disorder with other mental health disorders did not have a predictive diagnostic value. You couldn't say, if this person doesn't have depression, if this person doesn't have, I don't know, some other issue, for example, grandiosity, if this person doesn't self-harm and self-mutilate and doesn't have suicidal ideation, this person is not a borderline. You can't say this. It's wrong. The only two comorbidities which have some predictive value when it comes to borderline personality disorder are generalized anxiety disorder in patients under age 45, especially very young patients, and histrionic personality disorder. Both were more frequent in the patients who did not meet the suicidal self-injury criterion. So it seems that there are two groups of borderline. Borderlines who are suicidal and self-injurious. These borderlines would tend to have anxiety and histrionic personality disorder. And borderlines who are self-destructive, self-harming, and these borderlines would not have usually or normally, or would have less, lower frequency of histrionic personality disorder. The patients who met the suicidality self-injury criterion were significantly more likely to have been hospitalized and reported more suicidal ideation at the time of the evaluation, wrote the researchers. There were no between-group differences on severity of depression, anxiety, or anger at the initial evaluation. There were no differences in social functioning, adolescent social functioning, likelihood of persistent unemployment or receiving disability benefits, childhood trauma or neglect. All these parameters were identical in the group of patients who were suicidal and self-harming, and in the group of patients who were not suicidal and were not self-injurious. All these parameters, I repeat them: social functioning, adolescent social functioning, likelihood of persistent unemployment or receiving disability benefits, childhood trauma or neglect. Zimmerman says, I suspect that there are a number of individuals whose BPD is not recognized because they don't have the more overt feature of self-injury or suicidal behavior. He calls this hidden BPD, hidden borderline personality disorder. Repeated self-injurious and suicidal behavior, he says, is not synonymous with borderline personality disorder, and clinicians should be aware that the absence of these behaviors does not rule out a diagnosis of borderline personality disorder. Monica Karski is the assistant professor of psychology in psychiatry and a senior fellow of the Personality Disorders Institute in Weill Cornell Medical College, New York City. She has a very long list of credentials. She is also a postdoctoral manager of the postdoctoral program in psychoanalysis, psychotherapy, etc., etc. Karski suggested to stop using the model, the Diagnostic and Statistical Manual Edition 4 text revision model. In other words, she says, don't use the list of 9 diagnostic criteria. This list is very misleading. It's very misleading. It's also culture bound. It includes gender bias. and it's polythetic. It leads equally to comorbidity with other disorders. It's a mess. The Diagnostic and Statistical Manual, edition 4, including the text revision, are a bloody mess. And they are a mess because they rely on lists and categories, whereas the human psyche and the human mind are not categorical, they are dimensional, and they are on a spectrum. So Karski suggests to use the alternative model or the alternate model for personality disorder in the Diagnostic and Statistical Manual 5th edition text revision. In the alternative model or alternate model of borderline personality disorder, first you rate the severity level of personality. You assess identity, relationship problems, intimacy issues, self-regulation. You note specific traits of personality disorders. And she says this will help clinicians who dread telling patients that they are borderline. I concur wholeheartedly. The alternative model in the DSM-5 is vastly superior to anything DSM-4 has to offer. It is regrettable that the insurance industry and the pharmaceutical industry have both intimidated the Diagnostic and Statistical Manual Committee into including the outdated and defunct language of the Diagnostic and Statistical Manual edition 4 in the 5th edition and in the text revision. Summary of this part: you don't have to self-harm, you don't have to self-mutilate, and you don't have to be suicidal to qualify for a diagnosis of borderline personality disorder. If you are emotionally dysregulated and your affect is unstable, you probably have borderline features and in all likelihood a borderline personality disorder. So this is the article. Go to the description for a bibliography. I'm going to read to you what the authors said in the article itself. Background. Despite the significant psychosocial morbidity associated with borderline personality disorder, its under-recognition is a significant clinical problem. BPD is likely underdiagnosed in part because patients with BPD usually present with chief complaints associated with mood, anxiety, and substance abuse disorders. When patients with BPD do not exhibit self-harm behavior, we suspect that BPD is less likely to be recognized. An important question is whether the absence of this criterion, which might attenuate the likelihood of recognizing and diagnosing the disorder, identifies a subgroup of patients with BPD who are less borderline than patients with BPD who do not manifest this criterion. The results are this. Approximately half of the patients with BPD did not meet the suicidality self-injury diagnostic criterion for the disorder. There were no differences between the patients who did and did not meet this criterion in terms of occupational impairment, likelihood of receiving disability payments, impairment in social functioning, level of educational achievement, comorbid psychiatric disorders, history of childhood trauma, or severity of depression, anxiety, or anger upon presentation for treatment. And just correcting one thing, the only exceptions are generalized anxiety disorder in patients under age 40 and histrionic personality disorder throughout the lifespan. These two are correlated with borderline personality disorder. The comorbidity is significant, statistically speaking. The conclusions of the study: repeated self-injurious and suicidal behavior is not synonymous with borderline personality disorder. It is critical for clinicians to be aware that the absence of repeated self-injury and suicide threats or gestures or attempts does not rule out the diagnosis of borderline personality disorder. Onward to the next article. It identified a new treatment modality for borderline personality disorder. Hitherto, we have had mostly dialectical behavioral therapy, DBT. DBT has been extremely efficacious. Well over 50% of patients lost the diagnosis within 1 year. A DPD involved a group element and an individual therapy element. To this very day, DBT, dialectical behavior therapy, is the gold standard for treating borderline personality disorder. And here comes another possibility. I'm referring to an article titled "The Effectiveness of Predominantly Group Schema Therapy and Combined Individual and Group Schema Therapy for Borderline Personality Disorder," a randomized clinical trial. The lead author is Arnold Arntz, A-R-N-T-Z. And I will read to you the key points and findings from the study itself, but I want to discuss it a bit beforehand. What the study shows is that if you were to combine individual schema therapy with group schema therapy, you would accomplish a reduction of symptoms, a substantial reduction of symptoms in patients with borderline personality disorder. That's a new tool in our arsenal. Schema is a form of psychotherapy that focuses on the experience, on experiential approach. It's not so focused on behavior change. It teaches you how to manage your experience in ways which render you more functional and definitely more self-aware. This study, again, the lead author was Dr. Arnold Arntz. This study was an international randomized control trial. And what the study found was that it's not enough to offer individual schema therapy. You need to couple it with group schema therapy. And so what Dr. Arntz says is, in the Netherlands, there's a big push from mental health institutes to deliver treatments in group therapy only, because people think it's more cost effective. But these findings question this idea. The findings were published in a very prestigious academic journal, Journal of American Medical Association, Psychiatry. The study characterizes borderline personality disorder a bit idiosyncratically, I must say. Many scholars would disagree with some of the characteristics of borderline personality disorder as incorporated in this study. The study says that patients with borderline personality disorder exhibit extreme sensitivity to interpersonal slights. This kind of hypervigilance is actually much more typical in narcissistic personality disorder, not in borderline personality disorder. The study says that patients with BPD have intense and volatile emotions, which is true, as we've seen in the previous study. Impulsive behaviors, also true. Many of them abuse drugs, self-harm, or attempt suicide. Wrong, it seems. About half of them do, not many of them. At any rate, borderline personality disorder is, by and large, captured appropriately in the study. So we can't disqualify the study as having explored other mental health disorders. Patients in the study were clearly borderline. And when we look at evidence-based recommendations by various psychiatric and psychological associations around the world, the usual first venue or first resort is psychotherapy. Psychotherapy is the primary treatment for people presenting with what appears to be borderline personality disorder. And so we need many more therapies. Classical therapies such as psychoanalysis or even cognitive behavior therapy have proven to be inefficacious with borderline, hence the modification of DBT. Schema therapy uses techniques from traditional psychotherapy, but it focuses, as I said, on an experiential strategy. It delves into early childhood experiences. And in the case of borderline personality disorder, this is very relevant because in the vast majority of patients with borderline personality disorder, we do find adverse childhood experiences, trauma, abuse, and neglect in early life. That is not to say that borderline personality disorder is not a brain abnormality. It's not to say that there is no genetic or hereditary component in borderline. It seems that people who go on to develop borderline personality disorder as early as childhood, in childhood or adolescence, are people who have a propensity, a proclivity, a predilection to develop borderline personality disorder, genetically or cerebrally in the brain. In other words, these people are somehow predisposed to develop borderline personality disorder because they have defective genes or brain abnormalities. But the trigger is environmental, nurture, not nature. In the absence of abuse, trauma, and neglect in early childhood, you're very unlikely to develop borderline personality disorder, even if you have all the genes and all the brain abnormalities. So schema therapy seems to be very relevant. With this approach, therapists take on a kind of parenting role, and they try to meet the needs of these patients that were not met in early childhood. The patient is perceived as a frustrated child, and the role of the therapist is to help the patient grow up and mature by acting the parent. Previous research had suggested that both individual and group schema therapy help to reduce BPD symptoms. But what this study shows is that if you were to combine individual and group schema therapy, the benefit becomes exponential. Treatment retention is also higher when you combine the therapy. There's the improvement in multiple secondary outcomes, happiness, quality of life. Patient reports an enhanced sense of well-being. Still, just to put things in perspective, outcomes in society or in work are more improved in DBT than they are in this combined approach. I want to be clear. Combining individual schema therapy and group schema therapy does improve societal and work functioning patterns and outcomes, but not as much as DBT. So Arendt says that group therapy seems to offer something that is important for learning to cooperate with other people. At work, you often have to collaborate with people who are not necessarily your friends. It's the same approach in DBT, by the way. There's a very strong, dominant group element there. The number of suicide attempts among patients exposed to combined schema therapy, the number of suicide attempts declined over time. The combination proved to be significantly superior to treatment as usual. During the study period, 3 patients died of suicide, 1 in each treatment arm. The third one it wasn't clear that it was suicide. So these are 3 out of hundreds. It's a major improvement in the statistics of suicide in typical borderline groups. Overall, the results suggest that group and individual sessions address different needs of patients, said the investigators. While patients may learn to get along with others in a group setting, they may be more comfortable discussing severe trauma or suicidal ideation or thoughts in one-on-one sessions with a therapist. So let me read to you from the study. And again, go to the description. There's a bibliography with a list of all these studies and where to find them. Let me read to you the key points of the study. The question was, is group schema therapy for borderline personality disorder more effective than optimal treatment as usual? And is predominantly group schema therapy or combined individual and group schema therapy more effective? The findings. In this randomized clinical trial, which included 495 adult participants with borderline personality disorder in 5 countries, combined individual and group schema therapy was significantly more effective than optimal treatment as usual and predominantly group schema therapy. So the combination was much more effective in reducing BPD severity. The findings add to the evidence for the effectiveness of chemotherapy for borderline personality disorder and indicate that the combination of individual and group chemotherapy is the more effective chemotherapy for MAD. Okay, let's go on to the next study. And the next study kind of challenges the common orthodox wisdom in all the treatment guidelines that I'm aware of all over the world. If this study is replicated and supported by other studies, we have been doing things wrong for decades. According to this study, and in a minute I'll read to you the title of the study, give me a minute. Effect of 3 forms of early intervention for young people with borderline personality disorder. The MOBI, M-O-B-Y, randomized clinical trial. The lead author is Andrew Chanen, C-H-A-N-E-N. And as usual, I'll first analyze the study and then read to you from the study. What the study says is that early interventions that focus on clinical case management and psychiatric care and not on individual psychotherapy are more effective for young patients with borderline personality disorder. Now, you remember that we can diagnose and do diagnose borderline personality disorder as early as 12 years old. It's not the case with narcissistic and antisocial personality disorder, which are diagnosed only after age 18 or sometimes 21. Borderline can be diagnosed very, very early on in life. And so we have patients, they're underage, and we need to treat them somehow. And hitherto, all the treatment guidelines all over the world said that what you do with such a young patient is give him or her psychotherapy. And what this study says, it's a wrong approach. You should focus on clinical case management. You should focus on psychiatric care, including medication. And there is this trial, big trial, called Monitoring Outcomes of Borderline Personality Disorder in Youth, the MOBI trial, M-O-B-Y trial. It showed improved psychosocial functioning and reduced suicidal ideation with early psychiatric intervention and case management. So the results of this study suggest that psychotherapy is not the only or even first effective approach for early BPD. Dr. Chanen is the Director of Clinical Programs and Services and Head of Personality Disorder Research at Origin, Melbourne, Australia. And he said, we can say that early diagnosis and early treatment is effective, and the treatment doesn't need to involve individual psychotherapy, but does need to involve clinical case management and psychiatric care. Patients with BPD have extreme sensitivity to interpersonal slights and exhibit all kinds of volatile emotions and impulsive behavior. As we said, many self-harm, abuse drugs, attempt suicide. The suicide rate among patients with borderline personality disorder, to remind you, is anywhere between 8 and 11%, depending on the country. The condition is diagnosed in puberty or early adulthood, and it affects about 3% of young people. Luckily for humanity, many of these young people grow out of their borderline personality disorder. There are 2 waves where you can lose the diagnosis, between ages 12 and 21, and then after age 45. Only 1/3 of young adults or adolescents diagnosed with borderline personality disorder go on to become adults with a diagnosis of borderline personality disorder. But these patients, young patients, they are volatile, they're labile, they're dysregulated, they're aggressive, they have enormous interpersonal difficulties, and they're discriminated against by health professionals. They don't get treated. Those that are treated are often shunted off to some therapist once a month or something, and they receive individual psychotherapy. A very small percentage of them end up in dialectical behavior therapy program. And so, let me be clear, individual psychotherapy is a good thing. These therapies, especially DBT, teach you healthy ways to cope with stress and to regulate emotions. And so these therapies are highly effective. But the MOBI trial examined 3 treatment approaches, not only one. The first treatment approach is called the Help Young People Early model, HYPE. The second is HYPE combined with weekly befriending. And the third was a General Youth Mental Health Service, YMHS model, combined with befriending. So a key element of HYPE is cognitive analytic therapy. It's a psychotherapy program focused on understanding problematic self-management and interpersonal relationship patterns. The model also includes clinical case management, for example, housing, vocational and educational issues, other mental health needs, comorbidities like depression and anxiety, medication, physical health needs. In the second model, psychotherapy of the HYPE program is replaced. You have all the elements of clinical case management, but instead of psychotherapy, you have befriending. Befriending means chatting with the patient. The chats are about neutral topics. I don't know, sports, avoiding emotionally loaded topics, avoiding actually, not discussing interpersonal problems. And the third approach was YMHS plus befriending. It's when you the experts trained young people. They gave the young people therapy, they managed the patients, but these therapists were not specialists in BPD. So the third approach is what we call as usual treatment, or treatment as usual approach. Therapists, psychologists who are not experts and scholars of BPD, but treat BPD as well. All patients across all 3 groups had marked and sustained improvements in ways you wouldn't expect for borderline personality disorder. Interventions have a true effect, especially in childhood and puberty. The results suggest that early diagnosis and not very complicated treatment, or even just chatting to someone, drastically improves the lives of these young people, says Chanan. The results also imply that there are effective alternatives to mere treatment as usual psychotherapy. The insistence on the field by many scholars and many institutions and many treatment guidelines, the insistence that only therapy works in BPD is wrong. Chanan says this study turns things upside down and says actually that psychotherapy is not the single modality. It's the basics of treatment that are important, not which treatment. When a patient presents at an emergency department following, for example, severe overdose, clinicians reflexively refer that person to a psychotherapy program. But the problem is, these programs are not built to service the needs of suicidal borderline personality disorder patients. They are kind of canvassing programs. And most of the workers in these programs, albeit with academic degrees in psychology, are not experts in the extremely convoluted and complicated dynamic of borderline personality disorder. The skills for clinical case management and psychiatric care are very specialized. So this is the study. John Oldham, who is a distinguished emeritus professor in the Menninger Department of Psychiatry and Behavioral Sciences in Baylor College of Medicine, Houston, Texas, Oldham says the general standard approach in psychiatry and the diagnostic world has been to not even consider anything until after somebody is 18 years of age, which is a mistake. because these kids can become quite impaired much earlier than that, he says, and correctly. Oldham was not involved in this study. Ironically, he was one of the main contributors and authors of the very treatment guidelines which are undermined by this study. And yet, amazingly at his age and with his renommee and track record, Oldham is an example of a good scientist. A scientist who is open to new information. Scientist who is capable of modifying his views very substantially when exposed to new findings. Oldham says there is an emerging trend towards good psychiatric management that focuses on level of functioning rather than on a specific strategy requiring a certificate of training that not many people out there have, Oldham says. You're not going to make much headway, he concludes, with these kids. You're not going to make much headway with these kids if you are going to be searching around for a DBT certified therapist. What you need is to bring them in, get them to trust you, and in a sense, to be a kind of overall behavioral medicine navigator for them. Let me read to you from the study, as I usually do. By the way, the study comes with a beautiful graphic. And so the study, the key points are: question, what combination of treatment components is sufficient for early intervention for young people with borderline personality disorder? And the findings in this randomized clinical trial with 139 youth with borderline personality disorder, a dedicated BPD service model and a specialized BPD psychotherapy were associated with superior retention in care, but not a superior rate of change in psychological functioning by 12 months. And this is compared with general youth mental health care and a psychotherapy controlled condition. Effective early intervention for BPD is not reliant on availability of BPD psychotherapy. This is a major change in orientation. It means that when we are confronted with a young BPD patient, we should immediately take care of all the aspects of his functioning and his life. We should befriend him, and we should offer a complete, a total solution, not focus on psychotherapy, which often doesn't work or works less effectively, and there are very few people qualified to administer it. And so now I want to review 6 studies of psychosocial interventions. It is an article titled Borderline Personality Disorder, 6 Studies of Psychosocial Interventions by Sai Atezaz Said and Angela Kallis, Kallis. It was published in the Journal of Current Psychiatry in 2002. So the first study is by Zanarini, Konki, and Temis. But before we go there, a reminder of what is borderline personality disorder. Borderline personality disorder is a serious impairment on multiple levels and in multiple areas of life, starting with emotional dysregulation and affect instability. But psychosocial functioning is severely affected. There's an ongoing pattern of mood instability or lability, cognitive distortions, problems with self-image, impulsive behavior that often results in problems in the workplace and in relationships. Patients with BPD tend to utilize more mental health services than patients with any other mental health disorder or even with major depressive disorder. Many clinicians believe that BPD is very difficult to treat. This is no longer true. This hasn't been true for decades, but the stigma lingers on. Historically, there's been little consensus on the best treatments for these disorders. And currently, we use pharmacologic and psychological interventions in combination. And so I want to review 6 studies very briefly. So again, the first one is titled Randomized Controlled Trial of Web-Based Psychoeducation for Women with Borderline Personality Disorder. It was published in the Journal of Clinical Psychiatry in 2018. The authors are Zanarini, Conchi, and Temis. I'm reading the abstract. Research has shown that BPD is a treatable illness with a more favorable prognosis than previously believed. Despite this, patients often experience difficulty accessing the most up-to-date information on BPD, which can impede their treatment. A 2008 study by Zanarini et al. Of younger female patients with BPD demonstrated that immediate in-person psychoeducation improved impulsivity and relationships. Widespread implementation of this program proved problematic, however, due to cost and personnel constraints. To resolve this issue, researchers developed an internet-based version of the program. In a 2018 follow-up study, Zanarini and his collaborators examined the effect of this internet-based psychoeducation program on symptoms of BPD. And the outcomes were pretty astonishing. In the acute phase, treatment group participants experienced statistically significant improvements in all 10 endpoints and outcomes. It seems that in patients with BPD, internet-based psychoeducation reduced symptom severity and improved psychosocial functioning, with effects lasting up to 1 year. Treatment group participants experienced clinically significant improvements in all outcomes measured during the acute phase of the study. Most improvements were maintained over 1 year. So this is pretty interesting. A pretty interesting study. The next study is a randomized trial of brief dialectical behavioral therapy skills training in suicidal patients suffering from borderline disorder. It was published in Acta Psychiatry Scandinavia 2017. The authors were McCain and Guimont and Baunhart. So they said, standard dialectical behavioral therapy, DBT, is an effective treatment for BPD. However, access is often limited by shortages of clinicians and resources. Therefore, it has become increasingly common for clinical settings to offer patients only the skills training component of DBT, which requires fewer resources. While several clinical trials examining brief DBT skills, only treatment for BPD. So while several clinical trials examining this shortened or condensed version of DBT for BPD, these studies have shown promising results. It is unclear how effective this kind of intervention is at reducing suicidal or non-suicidal self-injury episodes. So the study explored the effectiveness of brief DBT skills, only adjunctive treatment on the rates of suicide and NSSI episodes in patients with BPD. I'll summarize this for you. DBT is expensive, DBT is costly, DBT requires training. DBT is not available everywhere to everyone. So there's a sort of zipped or condensed version of DBT, which offers only skills training. The authors tried to find out if BPD patients subjected to abridged DBT, the skills training component of DBT, if these patients responded favorably to the treatment by reducing rates of suicide and self-injury, which was not suicide. And so the outcomes were that the DBT group showed statistically significant greater reductions in the frequency of suicidal and NSSI episodes. So the DBT group experienced statistically significant improvements in distress tolerance and emotion regulations, but no difference on mindfulness. The DBT group achieved greater reductions in anger over time. So it seems that, yes, there are impacts. Even if we use only a single component of DBT, it already has massive effects on multiple very crucial dimensions of BPD. The DBT group showed significant improvements in social adjustment, symptom distress, and borderline symptoms, but no significant change in impulsivity. Clinical improvements were the statistical measures are very significant, so it's pretty safe to say that these outcomes are real. The conclusions are: brief DBT skills training reduced suicidal and NSSI self-injury episodes in patients with BPD. Participants in the DBT group also demonstrated greater improvements in anger, distress tolerance, and emotion regulation compared to the control group. These results were evident 3 months after treatment. However, any gains in healthcare utilization, social adjustment, symptom distress, and borderline symptoms diminished or did not differ from the other participants at week 32. At that time, participants in the DBT group demonstrated a similar level of symptomatology as the control group. So this was the second study. The next study is titled Combined Therapy with Interpersonal Psychotherapy Adapted for Borderline Personality Disorder. A 2 years follow-up was published in Psychiatry Research in 2016. The authors are Bosatello and Bellino. I love Italian, how musical. The study was interesting. It says that psychotherapeutic options for treating BPD, including DBT, mentalization-based treatment, schema-focused therapy, transference-based psychotherapy, and systems training for emotional predictability and problem solving. All these are psychotherapeutic options, but they're not widely available. More recently, interpersonal therapy also has been adopted for BPD. It is known as IPT-BPD. However, thus far, say the authors, no trials have investigated the long-term effects of this particular therapy on BPD. In 2010, Bellino et al. Published a 32-week study examining the effect of IPT-BPD on BPD. They concluded that IPT-BPD, in other words, interpersonal therapy adapted for BPD, they concluded that IPT-BPD plus Prozac was superior to Prozac alone in improving symptoms and quality of life. The present study by Bosatello et al. Examined whether the benefits of IPT-BPD plus Prozac demonstrated in the 2010 study persisted over a 24-month follow-up. And so the outcomes were, while the original study demonstrated that combined therapy had a clinically significant effect over Prozac alone on BPD, this advantage was maintained only at the 6-month assessment. The improvement that the combined therapy provided over Prozac monotherapy with regards to impulsivity and interpersonal relationships, as well as factors of social and psychological functioning at 32 weeks, were preserved at 24 months. No additional improvements have been seen. The conclusions of the study are that the improvements in impulsivity, interpersonal functioning, social functioning, and psychological functioning at 32 weeks seen with IPT-BPD plus Prozac compared with Prozac alone persisted for 2 years after completing therapy, but no further improvements were seen. The improvements to anxiety and affective instability that combined therapy demonstrated over Prozac monotherapy at 32 weeks were not maintained after 24 months. So the next study is favorable outcome of long-term combined psychotherapy for patients with borderline personality disorder. 6-year follow-up of a randomized study. Again, in Psychotherapy Research, 2017. The authors were Antonsen, Kvarstein, and Ernest. While many studies have demonstrated the benefits of psychotherapy for treating personality disorders, say the authors, there is limited research on how different levels of psychotherapy may impact treatment outcomes. There is something called the Uleval Personality Project. It compared an intensive combined treatment program with outpatient individual psychotherapy in patients with personality disorders. The combined treatment program consisted of short-term day hospital treatment followed by outpatient combined group and individual psychotherapy. The outcomes evaluated included suicide attempts, suicidal thoughts, self-injury, psychosocial functioning, symptom distress, and interpersonal and personality problems. A 6-year follow-up concluded that there were no differences in outcomes between the two treatment groups. However, the authors examined whether combined therapy, the combined psychotherapy, produced statistically significant benefits over the outpatient therapy in a subset of patients with borderline personality disorder. So you remember that the group included many types of personality disorders. So these authors wanted to home in, to focus on patients with borderline personality disorder and to see whether combined therapy was superior to outpatient therapy in the case of BPD only. So they discovered that when it comes to BPD, borderline personality disorder, compared to the outpatient group, the combined psychotherapy group demonstrated statistically significant reductions in symptom distress at year 6. And between years 3 and 6, the combined psychotherapy group continued to show improvements in psychosocial functioning. So the outpatient psychotherapy group worsened during this time. The scores of this group worsened during this time compared to the outpatient group. Participants in the composite group also had significantly better outcomes on multiple domains of self-control and identity integration. There were no significant differences between groups on the proportion of participants who engage in self-harm or experience suicidal thoughts or attempts. There were no significant differences in outcomes between the treatment groups in all these domains. Participants in the composite group tended to use fewer psychotropic medications than those in the outpatient groups over time, but this difference was not statistically significant. The two groups did not differ in the use of healthcare services over the last year. Avoidant personality disorder did not have a significant moderator effect in this case. Comorbid avoidant personality disorder was actually a negative predictor, independent of the group. Both groups experienced a remission rate of 90% at 6-year follow-up. Compared with the outpatient group, participants in the composite group experienced significantly greater reductions in symptom distress and improvements in self-control and identity integration at 6 years. So this is the study. The next study is 8-year prospective follow-up of mentalization-based treatment versus structured clinical management for people with borderline personality disorder. It was published in the Journal of Personality Disorders, 2021, and the authors are Bateman, Constantinou, and Fonagy. They say the efficacy of various psychotherapies for symptoms of BPD has been well established. However, there is limited evidence that these effects persist over time. In 2009, Bateman and others conducted an 18-month study comparing the effectiveness of outpatient mentalization-based treatment, MBT, against structured clinical management for patients with BPD. Both groups experienced substantial improvements, but patients assigned to mentalization-based treatment demonstrated greater improvement in clinically significant problems, including suicide attempts and hospitalization. In a 2021 follow-up to this study, Bateman and allies investigated whether the MBT group, the mentalization group, the gains in this group in the primary outcomes, absence of severe self-harm, suicide attempts, and inpatient admissions in the previous 12 months, the gains in social functioning, the gains in vocational engagement, mental health service usage, whether these gains were maintained throughout an 8-year follow-up period. And so the outcomes were that the number of participants who met diagnostic criteria for BPD at the 1-year follow-up was significantly lower at the mentalization-based group compared with the other group. To improve participant retention, this outcome was not evaluated at later visits. The number of participants who achieved the primary recovery criteria of the original trial, to remind you, absence of self-harm, suicide attempts, and inpatient admissions. The number of patients who achieved these primary recovery criteria and remained well throughout the entire follow-up period was significantly higher in the mentalization group compared with the other group. The average number of years during which participants failed to meet recovery criteria was significantly greater in the other group compared to the mentalization group. When controlling for age, treatment group was a significant predictor of recovery during the follow-up period. Overall, significantly fewer participants in the mentalization group experienced critical incidents during the follow-up period, which was a very long follow-up period. Yeah. The other group, the non-mentalization group, used mental health services for a significantly greater number of follow-up years than the mentalization group. The likelihood of using crisis services did not statistically differ between the groups, but the first group, the non-mentalization group, used these services much more. MBT group participants spent more time in education, were less likely to be unemployed, were less likely to use social care interventions than the other group. People in the MBT group spent more months engaged in purposeful activity, etc., etc. They had fewer months of psychotherapeutic medication compared with the other group, and so on. The study demonstrated that patients with BPD significantly benefited from specialized therapies such as mentalization-based therapy. At the 1-year follow-up, the number of participants who met diagnostic criteria for BPD was significantly lower in the mentalization group. The number of participants who achieved the primary recovery criteria and remained well during the 8-year follow-up period was also significantly higher in the mentalization group. So mentalization is a third option after DBT and schema therapy. And finally, a sigh of relief. Finally, an article titled Effectiveness and Safety of the Adjunctive Use of an Internet-Based Self-Management Intervention for Borderline Personality Disorder, in addition to care as usual, results from a randomized controlled trial. It was published in the BMJ, Open Access BMJ 2021. The authors are Klein, Hauer, and Berger. They say fewer than 1 in 4 patients with BPD have access to effective psychotherapies. The use of internet-based self-management interventions developed from evidence-based psychotherapies can help close this treatment gap. Although the efficacy of internet for several mental health disorders has been demonstrated in multiple meta-analyses, results for BPD are mixed. In this study, Klein and allies examined the effectiveness and safety of the adjunctive use of an internet-based self-management intervention based on schema therapy, in addition to care as usual in patients with BPD. So the outcomes were there were large reductions in the severity of BPD symptoms as measured in various ways in people who used an internet-based intervention method, and this difference was statistically significant. There was no statistically significant difference in the number of serious adverse events between the two groups. So the conclusion was that treatment with an internet-based intervention module did not result in improved outcomes over care as usual. although the average reduction was greater in this group compared to the reduction in symptoms, was greater in this group compared to the control group, this difference was not statistically significant. The authors believe that because many of the patients were receiving psychotherapy, the study should be taken with a grain of salt. But it's interesting. It's interesting because many people resort to the internet as a first option. You know, support groups, forums, even internet-based psychotherapy. This study seems to indicate that it's not working. Many groundbreaking and earth-shattering discoveries. I thought I'd bring them to your attention. Thank you for surviving, and see you next time. Good afternoon, dear students. This is a half-credit lecture for the CIAPS outreach program of CIAS, Center for International Advanced Professional Studies, those of you who had forgotten during the pandemic. And another thing you had forgotten is to hand in your assignments. Half of you, more than half of you, haven't done so. I don't know, you're twiddling your thumbs. Or, shudder the thought, twiddling some other part of you. So quit twiddling and start handing in, submitting your assignments from the last lecture. Last lectures, actually. Okay, enough with hectoring and preaching. Today we are going to discuss meaning, the role of meaning in therapy. And we are going to use 3 examples, 3 treatment modalities, 3 therapies, which have based themselves explicitly on the meaning of life, on introducing meaning, context, and sense into the client's life, or deriving meaning, context, and sense out of the patient's or client's life and the way he describes his life, also known in clinical terms as personal narrative. Meaning is a very important thing. I tend to agree with Viktor Frankl, who had suggested that Freud got it essentially wrong when he said that life revolves around pleasure, that Adler got it wrong when he had suggested that life revolves around power, and that life actually revolves around making sense, significance, meaning, direction, goal, purpose, structure, and order. In this sense, Jordan Peterson is right when he posits chaos against order and claims that order is the key to mental health. And so today we are going to discuss meaning. How do we introduce meaning into a life that ostensibly is chaotic, is all over the place, discombobulated, disintegrated? How do we impose structure and order on people who decompensate, who defiantly and contumaciously reactants, on people who confuse external objects and internal objects? In short, how do we make sense of mental illness? And once we make sense of the lives of the mentally ill, do they stop being mentally ill? Is this the key? Were these people simply anomic? Are people with mental illness simply people who fail to make sense of the world, of their lives, who find no meaning, no purpose, no direction, no structure, no order? Is this why many of them end up in hermeneutic, explanatory, and organizing systems like religion? Because there they find what they're missing? And are these solutions, like religion, not much worse than the problem? Swapping one delusion for another, one illusion for another, is this an acceptable mental health strategy? But We tend to do this a lot in our daily lives. What is love? What is love if not a delusional disorder? By the way, biochemically in the brain, it resembles very much a mental health disorder. I refer you to my video on this YouTube channel titled Love is a Pathology, where I summarize the latest findings. Love is indistinguishable, or more precisely the stage of limerence, the stage of infatuation, is indistinguishable from mental illness. And I'm talking about the brain, functional magnetic resonance imaging. So here we swap one intolerable situation, a meaningless life, for a delusion called love, because love structures our lives. Love gives us direction, purpose, goal, etc. In extreme cases, love deteriorates into stalking. Similarly, substance abuse, drugs, alcohol, they provide an exoskeleton. They imbue life with meaning, and that's why they are so difficult to eradicate, to reverse. That's why rehab is a spectacular failure, because rehab tackles the psychological and physiological elements of addiction, but does not tackle the nomological, the axiological aspects, the lack of meaning in the addict's life. So today I would like to discuss 3 treatment modalities which leverage meaning, use meaning as a healing tool. Let's start with the power, threat, meaning framework, PTMF or PTM framework. And I want to read to you what these people say about themselves. The PTMF framework was developed by both psychologists and psychiatrists. This was one group of psychologists and psychiatrists, and they teamed up with social workers, neighborhood activists, and so on. So they went down, they went to the grassroots. They went to the neighborhoods, they went to homeless people, they went to mentally ill people, they went to mental asylum. I mean, they dirtied their hands. They didn't stay in the lab or in this lecture hall and just theorize, and they didn't consider themselves public intellectuals. They considered themselves frontline health workers, and they collaborated with everyone who was fighting back, battling against the pandemic of mental illness, because that's by far a pandemic that's larger than COVID or anything else we have known. About 1/3 of the adult population in most Western countries is diagnosed with a major mental illness. So the power, threat, meaning framework, and now I'm reading from their own publication, is a new perspective on why people sometimes experience a whole range of forms of distress, confusion, fear, despair, and troubled or troubling behavior. And it is an alternative to the more traditional models based on psychiatric diagnosis. It was co-produced with service users and applies not just to people who have been in contact with the mental health or criminal justice systems, but to all of us. The framework summarizes and integrates a great deal of evidence about the role of various kinds of power in people's lives, the kinds of threat that misuses of power pose to us, and the ways we have learned as human beings to respond to threat. In traditional mental health practice, these threat responses are sometimes called symptoms. The framework also looks at how we make sense of these difficult experiences and how messages from wider society can increase our feelings of shame, self-blame, isolation, fear, and guilt. That's a bit I'm just cutting off right here to interject and say that it's very reminiscent of Pete Walker's rendition of flight, fight, fawn, and freeze responses. And I encourage you to have a look at that part of his work. He got it completely wrong on emotional flashbacks and many other things, but he expostulates very wisely and deeply and profoundly on these 4 types of responses. Continue with the text. The main aspects of the framework are summarized in these questions, which can apply to individuals, families, or social groups. Number 1, what has happened to you? How is power operating in your life? Number 2, how did it affect you? What kind of threats does this pose? Number 3, what sense did you make of it? What is the meaning of these situations and experiences to you? Number 4, what did you have to do to survive? What kinds of threat response are you using? In addition, the 2 questions below help us to think about what skills and resources people might have and how we might pull all these ideas and responses together into a personal narrative or a story. And this story comprises a few other questions or answers a few other questions. For example, what are your strengths? What access to power resources do you have? What is your story? How does it all fit together? So you see, this framework relies heavily on narrative construction. And there's a firm underlying assumption that by constructing a reasonable, internally consistent and externally consistent narrative, one can derive meaning, and that meaning empowers, and that empowerment is the first step towards healing and the disappearance of what we call today in traditional psychiatry symptoms. I'm continuing from the text of the PTM framework. Possible uses of the PTM framework. The power threat meaning framework can be used as a way of helping people to create more hopeful narratives or stories about their lives and the difficulties they may have faced or are still facing, instead of seeing themselves as blameworthy, weak, deficient, or quote-unquote mentally ill. The power threat meaning framework highlights the links between wider social factors such as poverty, discrimination, and inequality, along with traumas such as abuse and violence, and the resulting emotional distress or troubled behavior. The framework also shows why those of us who do not have an obvious history of trauma or adversity can still struggle to find a sense of self-worth, meaning, and identity. The framework describes the many different strategies people use, from automatic bodily reactions, somatization, to deliberately chosen ways of coping with overwhelming emotions, in regulating emotions, in order to survive and protect themselves and meet their core needs. The framework suggests a wide range of ways that may help people to move forward. For some people, this may be therapy or other standard interventions, including, if they help someone to cope, psychiatric drugs. But for other people, the main needs will be for practical help, for resources, perhaps along with peer support, art, music, exercise, nutrition, community activism, and so on. Underpinning all of this, the framework offers a new perspective on distress, which takes us beyond the individual and shows that we are all part of a wider struggle for a fairer society. One of the most important aspects of the framework is the attempt to outline common or typical patterns in the ways people respond to the negative impacts of power. In other words, patterns of meaning-based responses to threat. When we are confronted with threat, we seek meaning. This part of the framework, like all of it, is still a process in development. However, the evidence summarized in the framework does suggest that there are common ways in which people in a particular culture are likely to respond to certain kinds of threat, such as being excluded, rejected, trapped, coerced, or shamed. It may be useful to draw on these patterns to help develop people's personal stories. These general patterns can help to give people a message of acceptance and validation. The patterns can also assist us in designing services that meet people's real needs, as well as suggesting ways of accessing support, benefits, and so on that are not dependent on having a diagnosis. In addition, the framework offers a way of thinking about culturally specific understandings of distress without seeing them through a Western diagnostic model. So, in other words, the framework is not culture bound. It doesn't critically depend on a cultural context, a societal context, or a context of the period in history in which it operates. The framework encourages, I'm continuing from the text, the framework encourages respect for the many creative and non-medical ways of supporting people around the world, and the varied forms of narrative and healing practices that are used across cultures. And in concluding remarks, they say, taking the PTM framework further, it is important to note that power, threat, meaning is an overarching framework which is not intended to replace all the ways we currently think about and work with distress. Instead, the aim is to support and strengthen the many examples of good practice which already exist, while also suggesting new ways forward. The framework has wider implications than therapeutic or clinical work. The main document, and they're referring to a specific foundation document, suggests how it can offer constructive alternatives in the areas of service design and commissioning, professional training, research, service user involvement, and public information. There are also important implications for social policy and the wider role of equality and social justice. It is a work in progress offered as a resource for any individuals, groups, or organizations interested in developing it further. And I add that this framework is proving its value and its relevance, especially now during the pandemic, when traditional tools have been taken away from us, when we have been isolated and alienated from the familiar, when everything, including loved ones, can be perceived as a threat, and where whatever happens outside makes no sense whatsoever. And so our lives are rendered increasingly more meaningless. So the framework can help you restore meaning, create a new narrative, which will empower you in different ways and allow you to reintegrate with people, familiar people and new people. I strongly encourage you to delve into this. Everything is available online. They welcome contributors and contributions. Contributions, I don't mean money. Intellectual contributions, ideas, observations, shared experiences. They welcome all of you. So I strongly encourage. Now, the second treatment modality I would like to discuss, typically immodestly, is my own. I had developed a treatment modality dubbed cold therapy. Cold, like in cold therapy. Cold therapy, now with its extension, nothingness narrative construction. Cold therapy and nothingness narrative construction is all about meaning. I actually started my work on cold therapy by rereading Frankl's writings, and we'll come to Viktor Frankl a bit later. But cold therapy is about meaning. Cold therapy is a therapy that eliminates grandiosity. It eliminates grandiosity in narcissistic disorders of the self, including narcissistic personality disorder, and it eliminates grandiosity in depressive narratives. A big source, perhaps the biggest source of depression, dysphoria, anhedonia in people is the discrepancy between their expectations, their self-image, their self-perception, which is often inflated, illusory, delusional, grandiose, and reality. And I call this the grandiosity gap. Cold therapy works well with narcissists and with people, with depressive people with depressive illnesses, precisely because both narcissism and depression share a common etiology, the grandiosity gap, the gap between reality and how you would have liked to see yourself, what Freud called the ego ideal. Now here's the thing, grandiosity is a cognitive deficit. It impairs reality testing, of course. It distorts input from the outside to fit into the grandiose narrative. So in this sense, grandiosity and its agent, the false self, they provide the narcissist and the depressive with meaning. The false self is a narrative. It's a piece of fiction. It's a story. It's a movie. And it provides meaning, context, purpose, direction, goal. It has explanatory power and organizing power to generate structure and order in the narcissist's life. So when we take away the grandiosity, when we take away the false self, we actually dismantle the false self. Cold therapy is about dismantling the false self in narcissism and to some extent in depressive patients. So when you take away these, you take away the main engine of meaning in the narcissist's life. The narcissist is left with a life that appears to be arbitrary, capricious, threatening, hostile, meaningless. No context, no sense, no direction, no purpose, no nothing, no structure, no order. The narcissist drifts like a feather in a hurricane. He loses his bearings. He has no inner compass. The false self is an exoskeleton. It's an external skeleton, very similar to an addiction. It has the same psychodynamic functions of an addiction. It provides a narcissist with an external skeleton, something that holds him together. Take away this skeleton, take away this scaffolding, and the whole edifice of the narcissist crumbles because it's a house of cards. So when we take away the false self in cold therapy, we take away meaning. Now this meaning is delusional. It's pathological. It's based on a severe cognitive deficit. It has little to do with reality, so it impairs reality testing. It's not healthy, it's not good. The precondition for healing is to take away this distorted meaning and the generator of this meaning, which is the false self. So when you take away the false self, by dismantling it, the narcissist re-experiences, lives through. You remember the video about flashbacks? Revividness, relives his traumas. But this time, he's an adult. I take away his false self. He re-experiences his traumas because he has no protection left. It's like taking away the shell from a turtle. He becomes a turtle without a shell. And so he re-experiences the harshness of reality, the injuries, the mortifications, the traumas, the narrative, the disparaging narratives, the sadistic, hateful introjects. He experiences suddenly all this, and he has zero protection because he has no grandiosity and no false self. But this time he's an adult. And so this time he can try to make sense out of his harrowing, horrible life experiences. He can construct a new narrative that is not delusional, that is reality-based, that makes sense and gives his life structure, order, direction, meaning, and purpose. This is the core of cold therapy. It's forcing the narcissist, forcing the depressive patient to let go of a dysfunctional, delusional, sick, constricting, crippling, meaning-generating narrative, get rid of it, trash it, and then bravely and courageously face the pain, the fountain, the tsunami of pain and hurt and damage and shame and guilt to some extent. Have to face it and have to integrate it in a new story, in a new narrative that makes sense and would continue to make sense. Now in AA, Alcoholics Anonymous, they more or less force you to do the same, to go through the same path of letting go of your grandiosity and then having to face the people you've hurt during your alcoholic bouts, the damage you have caused, and then to integrate all this into a narrative of healing and recovery. It all boils down to the same, effectively. Get rid of dysfunctional pathological defenses, deficits, biases. Get rid, stop renouncing reality. Stop, as Cleckley called it, rejecting life. Embrace life, embrace who you are, flawed and invalid as you are. Accept yourself, nurture and parent yourself, or reparent yourself. Extricate yourself, this time with your own power, out of the trauma of your early childhood and heal. Heal via meaning, which leads us to the last treatment modality, and by far the most dominant and important, and that's logotherapy. Logotherapy was invented by Viktor Frankl. Viktor Frankl had the most amazing story. He survived in Auschwitz, the indescribable hell on earth, an inferno reified and embodied. In Poland, a concentration and extermination camp. Most people were lucky or unfortunate to survive 6 months in Auschwitz. This guy, Viktor Frankl, survived for 3.5 years. 3.5 years in hell, with devils and demons in human form, SS guards, and so on. And he has emerged with lessons. He's emerged with his mental health largely intact, a bit of grandiosity there, but largely intact. And he leveraged his experiences to help humanity. And he invented logotherapy. Logotherapy, I'm quoting now from the website of the Logotherapy Institute. Viktor Frankl's logotherapy is based on the premise that the human person is motivated by a will to meaning, an inner pull to find a meaning in life. The following list of tenets represents basic principles of logotherapy. 1. Life has meaning under all circumstances, even the most miserable ones, even in Auschwitz. Number 2. Our main motivation for living is our will to find meaning in life. Number 3. We have freedom. We have freedom to find meaning in what we do and what we experience, or at least in the stand that we take when we are faced with a situation of unchangeable suffering. How we react to suffering is in itself meaning or generates meaning. The human spirit referred to in logotherapy is defined as that which is uniquely human. Though in no way opposed to religion, the term is not used in a religious sense. So how do we discover meaning? According to Frankl, we can discover this meaning in life in 3 different ways. Number 1, by creating a work or doing a deed. Creativity. Number 2, by experiencing something or encountering someone. And number 3, by the attitude we take toward unavoidable suffering. Everything can be taken from a man, but one thing, the last of human freedoms, to choose one's attitude in any given set of circumstances. On the meaning of suffering, Frankl gives the following example. Once, an elderly old general practitioner consulted me, an old medical doctor consulted me because of his severe depression. He could not overcome the loss of his wife, who had died 2 years before and whom he had loved above all else. Now how could I help him? What should I tell him? I refrained from telling him anything, but instead I confronted him with a question. What would have happened, doctor, if you had died first and your wife would have had to survive you? Oh, he said, for her this would have been terrible. How she would have suffered. Whereupon I replied, you see, doctor, such a suffering has been spared her, and it is you who have spared her this suffering. But now you have to pay for it by surviving, by mourning her. He said no word, but he shook my hand and calmly left the office. Viktor Frankl vignette. All psychotherapies are based, of course, on implicit or explicit assumptions, usually implicit philosophical, even metaphysical assumptions. We make assumptions when we create a new psychotherapy. When I created my treatment modality, we make assumptions about what it is to be human, and more importantly, what it is to be a person. In other words, what it is to have a personality, to be distinguished, to be an individual. Is there such a thing? Some treatment modalities dispute it. They say individuals are not atoms. They are not divorced from their environment. There's no such thing as individual. That's a Western invention. So there's a lot of debate, and psychotherapies clash in their description of their subject matter, the patient or the client. None of these assumptions can be proven with certainty. It's not a science. It's literature at best and bad metaphysics at worst. The assumptions of logotherapy include the following. The human being is an entity consisting of body, mind, and spirit. So that excludes logotherapy for me. For example, because I'm a scientist by training. My original academic degrees are in physics. I cannot accept the concept of spirit. Things I cannot define don't exist for me. But it may apply to the vast majority of humanity who do believe in souls, spirits, ghosts, demons, and I don't know what else. So this is one assumption of logotherapy. Assumption number 2, life has meaning under all circumstances, even the most miserable. Even if when millions of people are exterminated in front of your eyes, in a horrible wintry camp in the middle of nowhere in Poland, Auschwitz. Number 3, people have a will to meaning. They want meaning, like Adler's will to power and Freud's will to pleasure. Indeed, Frankl suggested that this is the third school of psychoanalysis, this will to meaning. And number 4, people have freedom under all circumstances to activate the will to find meaning. Number 5, life has a demand quality to which people must respond if decisions are to be meaningful. And number 6, the individual is unique, which of course reflects biases of Western thinking, of the Enlightenment, biases that started in the 17th and 18th century and reached their apex in the 19th and 20th century. The concept of the individual, which is alien to cultures and societies, for example, in Asia and in some parts of Africa. So this is highly Western, it's Western-centered. The first assumption deals with the body, soma, the mind, psyche, the spirit, nous. According to Frankl, the body and the mind are what we have, and the spirit is what we are. Assumption number 2 is ultimate meaning. This is difficult to grasp, but it is something everyone experiences, and it represents an order in a world with laws that go beyond human laws. It's not the laws of nature. These are metaphysical laws, sometimes translated, sometimes they appear in the form of religion. But even when you're not religious, even when you're agnostic like me, or you have the religion of atheism, you're a non-deistic religious person, or your religion is science, even then, there are these unspoken laws, kind of ambient canon, codex of how the world behaves, the etiquette of existence, if you wish. The third assumption is seen as our main motivation for living and acting. When we see meaning, we are ready for any type of suffering. This is considered to be different than our will to achieve power and pleasure. Assumption 4 is that we are free to activate our will to find meaning, and this can be done under any circumstances. This deals with change of attitudes about unavoidable fate. Frankl was able to test the first 4 assumptions when he was confined in the concentration camps, and successfully so. Let me tell you this, any psychotherapy that helped someone survive Auschwitz is worth considering. The 5th assumption, the meaning of the moment, is more practical in daily living than ultimate meaning. Unlike ultimate meaning, the meaning of the moment can be found and fulfilled. This can be done by following the values of society or by following the voice of our conscience. Not much of a difference, by the way. Our conscience is internalized society. It's introjected via the process of socialization. The 6th assumption deals with one's sense of meaning. This is enhanced by the realization that we are irreplaceable, unique. In essence, all humans are unique, with an entity of body, mind, and spirit. We all go through unique situations. We are constantly looking to find meaning. We are free to do this at all times in response to certain demands. Viktor Frankl, like Sigmund Freud, was a neurologist, but unlike Sigmund Freud, he was also a psychiatrist. And he believed that the primary motivational force is meaning in life. He believes that if you're motivated by money, if you're motivated by sex or power, your motivation will not last long, and it will not sustain you as a functional, integrated entity. Meaning does this. Meaning is the glue that holds everything together. And when you look at models of the psyche, when parts in these models interact, and I'm not only talking about Freud's tripartite model, I'm talking about Jung's model, I'm not only talking about psychoanalytic or psychodynamic models or object relations models, any model, including behaviorist models. They necessitate meaning. A leads to B. This teleology is to some extent embedded. A leads to B because A needs to do something to B or with B in order to achieve C. There is one, if I were religious, I would say that there's a mind, a designer. But of course, evolution gives a sufficient answer for this, and God is, as Pascal said, an unnecessary assumption. So, logotherapy is in many respects existential. I mean, belongs to the school of existentialism. And it is openly, I mean, Frankl admits that he derived it from Kierkegaard's will to meaning. And Alfred Adler was influenced by Nietzsche's will to power, while Frankl was influenced by Kierkegaard and his will to meaning. Freud was influenced by Bleuler and others, and he came with a will to pleasure. Logotherapy says that you always strive to find meaning in life. This is the most primary, most foundational, most powerful, motivating and driving force. And I advise you to read the book Men's Search for Meaning, which is the accessible, because Frankl has many technical, highly obtuse and complicated books, which I also recommend to read. I mean, they're very, very important. But if you want to get the gist of it, and how shall I say, the spirit of it, then Man's Search for Meaning. In this book, he outlines how his theories helped him to survive the Holocaust, and how his experience, how he developed his experience, and how he generated his theories. Logotherapy, of course, is based, I mean, these are two words, logos and therapy. So logos is reason. Logos is also word. So logos is language. Logos is reason. Logos is the mind of God in action. If you read the New Testament, the first sentences about the logos. So he says that people are motivated by the logos. When they look at the world, when they look at the universe, there are two ways to look at your environment. Either you look at it and it's totally chaotic, totally random, totally meaningless, has no direction, purpose, and you say to yourself, when I see meaning, when I see direction, when I see purpose, I'm imposing myself on the universe. The universe is not like that. That's a delusion. These narratives are all, BS, because it's me. I'm inventing them. And if I'm the source of these narratives, they don't give real meaning. These narratives reflect more about my inner state, about my inner landscape, about my mental structures, constructs, introjects, than about reality. They say nothing about reality. And if I force reality, shoehorn reality to conform into these narratives, I'm just lying to myself. So that's one way of looking at the universe. And another way of looking at the universe is the way Frankl does, saying that, yeah, humans are the source of meaning, but that doesn't mean that meaning is meaningless. The fact that we are the source doesn't vitiate, negate, or undermine the power of meaning, the importance of meaning, and above all, the validity of meaning. We can come up with narratives which are meaningful, and these meanings will be sustained by reality. Science. What is science? Science is a set of narratives. Who creates science? We do. Only we do. I have yet to come across a giraffe who creates relativity theory. Humans create science. And yet, science resonates with the universe. The universe agrees, complies, obeys, follows science. Of course, it's a way of looking at it. The science makes sense of the universe, imbues it with some form of operational meaning, charts it, maps it, creates maps of meaning, to borrow from Jordan Peterson. So, science is an example of a meaningful narrative which is essentially human, only human, exclusively human, but still has its own standalone validity independent of the source. And so if we can do it with science, why can't we do it with metaphysics or philosophy? Or you know what? Perish the thought, religion. The human spirit imbues the work of Frankl. But his use of the word spirit is not spiritual. It's not religious. The spirit is the will. What Kierkegaard called the will. That's the spirit. It's the search for meaning. It's not a search for God. It's not a search for any supernatural being. It's not a search for the paranormal. The search for meaning, on the contrary, is very pedestrian. It's very quotidian. It's very detail-oriented. It's very, you search for meaning in your routine, in your daily life, in the people that surround you day in and day out, or Zoom with you day in and day out. You search for meaning in the virus. You search for meaning in the sick wards, in hospitals. You search for meaning in the trenches where millions of people die. You search for meaning in hunger. You search for meaning in love. You search for meaning in your children and your spouse and your boring and dull work. You don't search for meaning in heavens. You don't search for meaning in the kingdom of heaven that is about to come, or in the second coming, or in any guru or prophet or public intellectual. Or you don't search for meaning in these places. You search for meaning within yourself. Within yourself. Frankl warned against affluence, hedonism, materialism in the search for meaning. He said that these are gods with feet of clay. They're idols in the biblical sense. And their prophets are false prophets, all these coaches and so on. Frankl observed that it's actually psychologically damaging when our search for meaning is thwarted, blocked, frustrated, deformed, manipulated. Louis Althusser, with his interpellation. So positive life purpose, positive meaning could be associated with strong religious belief, or membership in some group, or dedication to a cause, or upholding certain life values and reifying them in your behavior, having clear goals. Purpose of life. Developing into an adult, maturing into an adult, implies having a purpose, having a structure, channeling, having a direction. And yes, in many respects, it implies narrowing your life. Channeling means being limited to a channel. And this is what Cleckley describes in his book, Mask of Sanity. Psychopaths, even gifted ones, even geniuses, and he dedicates a whole chapter to gifted psychopaths. Their problem is not that they're stupid, or even that they're insane, although he claims that they are functionally insane. Their problem is that they reject life. They reject life in the sense that they refuse to adhere to any purpose and any meaning in any direction and any order. They are defiant. In psychopathy, we call it reactance. Psychopaths are reactant. They have defiance, and they sacrifice their own. They would rather die than succumb, than accept the mores and edicts and expectations of society, of peers, of family, of institutions. They'd rather die, and they often die. So psychopathy is the rejection of meaning. The rejection of meaning, the rejection of maturation, and the rejection of life. Because to do this, you must comprehend life's purpose. You must direct it. You must have intention. Life is intentionality. Intentionality creates the feeling that life is meaningful. And there were many other scholars like Crumbo, Mahalik, and they designed even something called the purpose in life test, the PIL test. It measures individuals' meaning and purpose in life. And they found that in various studies that meaning in life mediated relationship between religiosity and well-being, for example, between stress, uncontrollable stress, and substance abuse, depression and self-derogation, etc., etc. They discovered that meaning is super critical. Seeking of noetic goals test, song, it's another measure that they had designs, and song measures the orientation towards meaning. So PIL measures the existence of meaning. Song measures orientation to find meaning, the drive to find meaning. So when you have a low score on PIL, you have low meaning in your life or no meaning in your life, and you have a high score on song, that predicts a better outcome in treatment than the opposite. Frankl himself suggested various ways of obtaining meaning, and I referred you to this, and I described the case of the general practitioner, the medical doctor, and so on and so forth. But like Jordan Peterson much later, Frankl emphasizes suffering. And of course, Jordan Peterson continues a very long tradition of debate about suffering. Buddhism is one way of considering suffering. Christianity, of course, is founded on suffering. Christianity is suffering reified. It's institutionalized suffering, especially in its more original forms, which is Catholicism. Strangely, Orthodox Christianity is centered around life and meaning, while Catholicism chose suffering and the negation of life, the denial of life. One could argue that perhaps Catholicism is far more psychopathic than other variants of Christianity. But let's not go into this. It's another video. But Frankl similarly realized the value of suffering. And he said that suffering is meaningful only, and here he's distinct from Peterson. He disagrees with Peterson. He says suffering is valuable, but only when first two creative possibilities are not available. In other words, when nothing else is available, when you can't create, when you can't be with people, when you can't socialize, when you can't do anything, when you're in a concentration camp, in other words, when your locus of control is totally external, your life is not your own, only then your suffering becomes meaningful. When Roman legionnaires march you through Jerusalem and then crucify you, you are utterly powerless. You're utterly helpless. You're utterly impotent. At that point, your suffering becomes meaningful, but only at that point. Because prior to that point, you have alternatives. And all alternatives are preferable to suffering. Frankl said that suffering is not meaningless if it can be avoided. Only when suffering is inevitable, it becomes meaningful. So he was dead set against suffering. And in this sense, he was a Buddhist. Of course, we'll talk about it in one of our next videos. He wrote another book, which I recommend to you. It's a bit more complex, and it's called The Will to Meaning, Foundations and Applications of Logotherapy. That's the philosophy and metaphysics of logotherapy. He makes some amazingly basic observations in this book that have eluded and evaded the greatest minds in psychology. For example, his opening sentence is essentially, there's no psychotherapy if we don't have a theory of the individual. Remember, he was an existentialist, and he disagreed with behaviorism. He disagreed that people are machines, or that they are evolved rats. Like if you experiment on rats in a laboratory, you learn everything you need to know about humans. He disagreed. He said that the difference between rats and humans is not a question of quantity, it's a question of quality. And he said that behaviorism is anti-human. It undermines the human quality of humans. He was a neurologist and he was a psychiatrist. And so when you couple these essentially mechanistic disciplines, because neurology is mechanistic, it's a machine, it's studying the machine, the machinery, the hardware of the brain. So when you couple this with existentialism, you come up with the equivalent of determinism. But how do you reconcile determinism with freedom of will, or the will to freedom, or the will to meaning? So there is an inherent time bomb in logotherapy. Frankl admits that a person can never be free from every condition. People are subjected to start with, physiological, biological, medical conditions, and then they're subjected to sociological, cultural conditions, and then they are subjected to psychological determinants. I mean, people are under so many constraints, and that it's very difficult to assert yourself, to exert yourself separately from these constraints. With many, many people, the constraints and the limitations and the rules become their identity. Their identity is comprised of what they cannot do, not what they can do. So he says that people are capable of resisting and braving even the worst conditions. He said you must rebel against these constraints. You must detach from the situation. You must choose an attitude. You must determine your own determinants. You must shape your own character. You must become responsible for yourself. You must fight back. Ecce Homo is a method used in logotherapy, and it requires the therapist to note the innate strengths that people have and how they have dealt with adversity and suffering in life. Despite everything a person may have gone through, they made the best of their suffering. And this is the Ecce Homo. Behold the man and his story. Behold the meaning that each and every one of us generates to a lesser or greater degree. Okay, assignments. I remind you, all your studies are meaningless without assignments. And what's even much worse, I'm meaningless without your assignments. So don't make me lose my job in this pandemic, because, you know, it's the only one I have. It's the thing that gives my life, endows my life with meaning. You wouldn't want to take this away from me. Thank you for listening. I received complaints from some Shoshanim that they had been discarded and replaced with baby seals and baby sealets. Worry not, my Shoshanim, you're always in my heart. You're the first and foremost. So, here goes. Okay, Shoshanim. Today we're going to deal with narrative. Narrative is our core identity. And what happens when narratives fail and how to fix them? My name is Сэм Вакнин. I'm the author of Malignant Self-Love, Narcissism Revisited. I am also a professor of psychology in CIAPS, Center for International Advanced Professional Studies, the outreach program of the CIAS Consortium of Universities. That was long, wasn't it? Okay. Disorders of the self, narcissism, borderline, can be easily construed as failures of narratives, failures of self-stories. Now, you know my view. I don't believe there is such a thing as a unitary, stable, immutable self across the lifespan. I believe that people have an assemblage of self-states which respond to and resonate with environmental stimuli and changes. But whichever the case may be, self-states, self, they have to be organized in a way which would make sense to the individual. They have to be put together somehow, according to some script, some story. And this story about yourself, who are you? Where are you headed to? What's the meaning of your life? What are your greatest aspirations? What are your hopes? What are your fears? All these put together in a coherent, cohesive framework is what is known as self-narrative. Now, in narcissism, the narrative breaks down. There's a failure of narrative because the narcissist adopts a story about himself or herself which has little to do with reality. The story is unrealistic, it's counterfactual, it's fantastic, very often grandiosely fantastic, but not only. For example, the shared fantasy is a narrative failure. The narrative, the self-narrative, has to be self-efficacious. It is intended to help us to survive. It is an evolutionary positive adaptation. Narratives that divorce us from reality, for example, a psychotic narrative or a narcissistic narrative, these narratives are narrative failures. It's the same in borderline. Borderline, we have identity disturbance. There is no fixed core. There's no identity. It's like a cloud, ephemeral, ever-changing, shape-shifting. You can't pinpoint or pin down the borderline. There's nobody there in the sense that everybody is there. The borderline changes sometimes within hours. Everything about her, including her values and beliefs and hopes and wishes and dreams, everything changes. And the borderline switches between self-states, rapidly cycles to the point that she is not. In both narcissism and borderline, we have a situation of absence. These are disorders of absence. In both of them, there's an empty schizoid core, kind of black hole, which does not contain any contiguous, jointed information. Everything, it's as if some improvised explosive device detonated amidst what should have been a core, a kernel of identity. And these are narrative failures. Now, there is something called narrative psychology, and there is something called narrative therapy, where we try to fix narratives. It's a form of psychotherapy. We help patients to identify values and skills which are associated with them. We provide the patient with some kind of knowledge or ability to experience these values and to exercise these skills in order to confront problems. And so the way we do this is we encourage self-authorship. We encourage the patient to co-author with a therapist a new narrative about themselves. And the patient does this by investigating the history of his or her values, the continuity of his or her skills. Narrative therapy is closely associated with other therapies, for example, collaborative therapy and person-centered therapy. There are several techniques in narrative therapy. We start with reoffering identity. The narrative therapist focuses on assisting the patient to create a story about himself. I'm going to use the male gender pronoun, but of course it applies to women as well. So the patient is encouraged to write a story about himself, about his identity, but the story has to be helpful in some way. It has to cope with some issue or problem or repetition compulsion. And the work of this reoffering one's identity helps the patients to identify values, skills, knowledge to exercise in order to live these values, and so on and so forth. The therapist just listens and questions and directs this process of authorship. Having identified or having pinned down or realized the personal history and the values attached to this personal history, now the patient is able to write a new narrative or to co-author a new narrative. The problem usually starts when there is a discrepancy between the narrative that a person tells himself and the stories that other people tell about the person. When there is a clash or a conflict or dissonance between what people say and think about you and what you say and think about yourself. This is very common in narcissism, and that's why narcissists have a grandiosity defense. Grandiosity is a cognitive distortion intended to uphold a fantasy, intended to prevent a dissonance between self-narrative and narratives about you from other people. And so the story of someone's identity determines not only who you are at any given moment, but also your potential for self-actualization. What do you believe is possible for yourself? In other words, your self-narrative defines your horizon. The narrative process allows you to identify values that are important to you, use your skills, and integrate your knowledge, but it is always focused on unique outcomes. It's a phrase coined by Irving Goffman. Unique outcomes, expectations or exceptions to the problem that wouldn't be predicted by the problem's narrative or story. Whenever we are faced with a problem, and I recommend that you watch my previous video about solving dilemmas, whenever you are faced with a problem itself is a narrative. And usually embedded in the problem, there's some form of catastrophizing. The problem actually communicates to you, I cannot be solved, or you are not good enough to solve me. And so rewriting or reauthoring your story creates unique outcomes in the sense that you find a way to solve the problem. You find an exception to the problem's overriding message, I am unresolvable. Another technique is called externalizing conversation. Narrative therapy is about constructing self-narratives, but of course self-narrative is a very important part, a very important component of core identity. So the approach in narrative therapy is not to conflate identities with self-narratives and not to mistake problems with identities. That is very, very reminiscent of the way cognitive behavioral therapy treats automatic negative thoughts. Automatic negative thoughts are narratives, in effect, or mini narratives. But the message of automatic negative thoughts is you cannot cope with your problems. They're never going to go away because your problems are who you are. Your problems are not just mistakes you have made, but they reflect on who you are. And so in narrative therapy, we teach the patient to separate narrative about who they are, self-story, from problems and issues in life, which have to do more with actions, choices, and decisions, not with who you are. The approach seeks to avoid actually the notion that the self is kind of biologically determined, that there is something like a true nature, a quiddity, an essence that you cannot escape. It's a bit deterministic, it's a bit fatalistic, and narrative therapy is the opposite of deterministic and fatalistic. It tells you you can rewrite yourself, you can reinvent yourself, you can become someone different just by sheer willpower, imagination, and creativity. We separate in narrative therapy identities, self-narratives, from problems. And we do this by externalizing conversations. The process of externalizing allows people to consider their relationships with their problems. And so externalizing focuses on your strengths, on your positive attributes, and allows you to construct and perform a new preferred identity, which is essentially a kind of positive psychology, if you wish. An externalizing emphasis is about naming a problem, getting a handle on it, so that a person can assess the problem's effects in his or her life, can analyze how the problem operates or works in his or her life, and can end the relationship with the problem. They can simply choose to disengage from the problem, ignore it in a way, or engage with it in a totally new way from a point of strength, emphasizing assets rather than liabilities. And this leads usually to something which a prominent narrative therapist, Michael White, had developed. It's called the statement of position map. The therapist is collaborating with the patient. It's a therapeutic posture. He doesn't impose ideas on the patient. He doesn't give the patient advice. He just, together with the patient, explores the patient's life and history, personal history, autobiography. Together, they uncover and examine a life unexamined. They remember things past, to borrow from another Jew, Marcel Proust. Michael White developed a conversation map, which, by the way, is somewhat reminiscent to the map of happiness in cold therapy. So he developed a conversation map called a statement of position map. It is designed to elicit the client's own evaluation of the problems and the developments in their life. The therapist and the client are perceived as having some kind of valuable information relevant to the process, and they create together, they co-create, they're co-creators, they co-create the content of the therapeutic conversation by imbuing it and suffusing it with this valuable information. The therapist has valuable information about healing. The patient has valuable information about the patient. So there's a position of curiosity. The therapist is curious about the patient. The patient is curious about what the therapist may have to say, and they collaborate. And there's an implicit message. You already have everything you need to transform your life. You have all the skills, you have all the values, you have all the knowledge to solve the problems that you're facing. Even if you have identity disturbance, you can leverage your kaleidoscopic nature. You can leverage this instability, this constant shape-shifting. These are not necessarily liabilities. These could be construed and used as assets in a new self-narrative or self-story, which is not deprecatory, not self-critical, and does not necessarily adhere or conform to social mores and so on. When people develop solutions to their own problems based on their own values, on their traits, on their decisions, choices, and behavior, on their personal history, they own the process. They become much more committed to implementing these solutions. A common practice in narrative therapy is remembering. The therapy identifies identities that are somehow sublimated, identities that are socially conformant or reflect somehow or denote social accomplishments and achievements. And the practice of remembering kind of puts together these identities which are socially condoned. It tries to coalesce them to support a person's preferred story about themselves. It disengages the identities that do not support the person. Again, very reminiscent of how cognitive behavior therapy deals with automatic negative thoughts, and similarly in Gestalt. Michael White is actually a proponent of Jacques Derrida, and he draws on his work. White was curious about the values that were implicit in people's pain, sense of failure, and actions which are self-destructive and self-defeating. What kind of values can motivate these? Why would anyone have a value or set of values which causes self-destruction? Why would anyone seek pain in a way by adopting certain values? Where does the sense of failure come from? If you do follow your values, you should feel great, you should feel egosyntonic, you should feel accomplished because you have been following your values. So why don't you? Why do you feel so bad ultimately? People feel pain or failure in relation to their values or how they would prefer their relationships or life to be. These are kind of stalled initiatives that people take in life, and they are also guided by implicit values, by rendering the hidden text overt, the implicit text explicit. By doing this, we actually bring to awareness conflicts, dissonances, and internal problems. Another map in narrative therapy is very big on maps. So another map is called the outsider witnesses map. It's again, everything in narrative therapy is a conversation between the therapist and the patient. This is a narrative practice. It's a practice of telling stories to each other. Sometimes outsider witnesses are invited as listeners in the consultation. It could be, I don't know, parents, good friends, enemies, spouses. Spouses are enemies. Okay, you know what I mean. People from the outside. So they are brought into the room, into the counseling process. And then they are asked to contribute. They're asked to contribute to the weaving of this yarn, of this quilt, to the weaving of this emerging story. And it is beautiful to behold the narrative process as it gives rise to a totally new identity and self-story, which are much more helpful and beneficial to the client. When outsiders are invited to the counseling or consultation room, and by the way, some outsiders could be, for example, other clients of the therapist who have gone through the process and they have knowledge and experience of the problem at hand. There's no limit or limitation on who is allowed into the room during the consultation. And so these people participate, and it becomes a community effort, very similar to group therapy in a way. And during the first interview between the therapist and the patient, even during the first interview, sometimes there's an outsider. The outsider listens without commenting. It's in order to be seen. The outsider's gaze helps the patient see himself or herself through an outsider's gaze. Maybe for the first time, the patient is really seen. The usual protocol for the involvement of outsiders in narrative therapy is to instruct them not to criticize the patient, not to evaluate the patient, not to rank the patient or give him or her marks, and not to make proclamations, opinionated proclamations about what they've just heard or what they've just seen. Outsiders are simply asked to say what phrase or image stood out for them in the narrative or the newly emergent narrative. They're asked to follow resonances between their own life struggles and the problems and issues they have just witnessed. The outsider is asked in what ways they may feel a shift in how they experience themselves from when they first entered the room. It is intended to demonstrate to the patient that every human interaction creates a shift. Every human interaction has an effect. Every human interaction hurts or elates. Nothing and no one is isolated. We're all relational. And so any narrative and self-story we may come up with has to take into account other people. The therapist turns to the consulting, to the patient. The patient has been listening all the while to the outsider, and then the therapist turns to him and interviews him about what images or phrases stood out in the conversation just heard, and what resonances have struck a chord with the patient. So there is a kind of intermediation. The therapist becomes a facilitator or a moderator between the inputs of the outsider and the inputs of the patient, and the resonances and interactions between these two inputs. At the end, an outsider witness conversation is very rewarding. It's very rewarding not only for the patient, but for the outsider as well. The outcomes are often remarkable where the patient is concerned. They learn that they're not the only one with this problem, for example. They acquire new images and knowledge about the problem, and they choose an alternative direction in life. The main aim of narrative therapy is to engage people with their problems by providing them with alternative, better or best solutions, which are essentially new self-stories, new identities, new self-narratives. And everything is documented. Everything is written down exactly as an author would do. Only this is a process of self-authorship with a guide or a facilitator. So the person and the counselor, they co-author certificates. There is, for example, a graduation from the blues certificate about overcoming depression. Sometimes case notes are created collaboratively with clients to provide documentation as well as markers of progress. I do the same in cold therapy. Rewriting who you are is a first step, not a last one. When you are faced with situations in life which are intractable, when you feel hopeless, when you feel there's nowhere to go, when you feel that it is your essence that is compromising your life, when you feel that who you are is the problem, then of course you need to change who you are. And here's the good news. You have the power to do so, because you are nothing but a dream. You are nothing but a storyline. You're nothing but a movie or a script or a theater play. You can rewrite yourself. You're the author of yourself, and you're the exclusive author of your own life. And people are out there, and they can provide you with sufficient input to guide you, calibrate you. Even evil people, people with ill intentions, they provide you with valuable input. They are part and parcel of the learning curve and experience. It's a teaching moment every moment. So trust your ability to become someone else, and trust the world to provide you with inputs and feedback which will keep you on track, which will allow you to gauge whether you are doing the right thing. Do not discard anything, information or data that comes from the world. All these stimuli, all these inputs are critical for your self-betterment, healing, or at the very least, enhanced self-efficacy in solving problems. Gradually, you will discover that you do have stable values, even as a borderline. Gradually, you will find out that reconstructing your narrative has amazing effects, not only on who you are, but on what's happening to you. And this is true even for narcissists. Cold therapy is actually a variant of narrative therapy, where we write out grandiosity and replace it with a self-narrative that is realistic and allows for enhanced self-efficacy in interpersonal relationships. Thank you for listening.